Hello and welcome to this brief discussion on the classification of anemia. Anemia is defined as the reduction in the red cell mass of an individual for that person's age and sex. Functionally, this would lead to a reduction in the oxygen carrying capacity of the blood, and this concept of a red cell mass is not very easy to measure practically. So, the parameters that we take or that we use to assess anemia is hemoglobin, hematocrit or packed cell volume, and to a certain extent the RBC count. Normally, this hematocrit and hemoglobin assessment gives a pretty good idea about whether a person is anemic or not. There are a few rare exceptions when this may not be reliable. For example, if there is a fluid overload condition or if the patient is dehydrated. In such scenarios, the hemoglobin value may be falsely low or falsely high respectively. Anemia is classified in many ways. This is because anemia is it's not a single disease entity. There are many types of anemias, and also there are various ways of classifying these various types of anemias. So, as a pathologist, one frequently used method is the morphological classification, depending on how an RBC looks. Now, normally an RBC, you may all remember from your physiology, it's described as a biconcave disc shaped cell. Now, unfortunately, RBCs cannot balance on their sides on a slide, so they are usually seen end on. So, we don't see any biconcave discs on a smear. We see only the round cells with a central pallor. This central pallor is what is indicative of that thin waist of an RBC. So, an RBC on the side is hourglass shaped, and from the end on view, you find a rim of hemoglobin which gives it a pink color and a central pallor. Now, the size of an RBC is 7 microns or 7.2 microns. Now, this is not a very easy measurement to assess with your naked eye or with a microscope. So, what we do is we compare it with a known cell of similar dimensions, and that particular cell is the mature lymphocyte. The nucleus of a mature lymphocyte is about the same size as an RBC. So, if an RBC, if you compare it to a lymphocyte nearby, and if it appears slightly smaller than the nucleus of that lymphocyte, then you call that an RBC a microcyte. Similarly, if it's much larger than the nucleus of a mature lymphocyte, you call it a macrocyte. If it's comparable in size, it becomes a normocyte. So, based on this morphological assessment, on the size of RBCs, you can call it either macrocytic, normocytic or microcytic. Similarly, based on the content of hemoglobin, I said that there is a central pallor to an RBC. This central pallor, the size of it depends on the amount of hemoglobin. If there is a lot of hemoglobin, the central pallor is small. If the amount of hemoglobin is very low, this central pallor becomes big. This central pallor is usually about 1/3 the diameter of the RBC. If it is more than 2/3 the diameter of an RBC, you call it hypochromic RBCs. So, based on this pallor or the hemoglobin content, you have two kinds of RBCs. You have normochromic RBCs where the central pallor is normal, and you have hypochromic RBCs where the central pallor is greater than 2/3 the diameter of the RBC. So, to recap, morphologically, based on size, you have macrocytes, normocytes and microcytes, and based on the chromia or the hemoglobin content, you have hypochromic RBCs and you have normochromic RBCs. So, taking all this together, there are three subtypes when you think of the morphological classification of anemia. The first one is normocytic normochromic anemia. That is, the RBC looks normal, it's of the normal size, it's of normal chromia, but at the same time hemoglobin is reduced. A condition which could lead to this is say chronic kidney disease where erythropoietin is insufficient. Another morphological subtype would be microcytic hypochromic anemia, where the RBCs are small in size and at the same time their color is also very pale. This is the prototype of this kind of anemia is iron deficiency anemia. The third type is macrocytic normochromic anemia, where the RBCs are large, and along with the RBCs in the same smear you may also find hypersegmented neutrophils. This finding is a feature of megaloblastic anemia. So, based on morphology, we have three subtypes: normocytic normochromic, microcytic hypochromic and macrocytic normochromic. Another method of classifying anemia would be to use the percentage of reticulocytes that you see in a smear. Reticulocytes are young RBCs. They have dissolved nuclear material in their cytoplasm, which using special stains you can highlight this nuclear material, and this material appears in the shape of a reticulum or a network. That is the reason these cells are called reticulocytes, and they are basically just infant or very young RBCs. A normal adult would have about 0.5 to 2.5% reticulocytes in his peripheral blood. If there is an increase in production of RBCs, you will have an increase in the number of reticulocytes, and if there is very reduced production of RBCs, the number of reticulocytes would also come down. So based on the amount of reticulocytes, anemia is classified as having low reticulocytes, as having normal reticulocytes, and as having a high reticulocyte proliferative index. Now this type of classification of anemia based on reticulocytes is called the kinetic classification. So we've discussed two types of classification, morphologic and kinetic, but both of these they have limitations. They are not very useful if you consider the management of the patient. This is because unless you know the real cause of anemia, it's difficult to treat anemia. So the third kind of classification is based on the cause of anemia. This is called the etiological classification of anemia. Now, etiology or the cause, once you know it, it's helpful to treat the patient because you can directly target whatever is causing that anemia. Based on etiology, again, anemia is subclassified into three main groups. One is anemia due to increased blood loss. The second is anemia due to increased red cell destruction. And the third one is anemia which occurs due to decreased red cell production. We will now take examples of each one by one and discuss a few pathogenic features of important varieties of each. The first one, that is anemia due to blood loss. It is self-explanatory. There are two subtypes in this. One is called acute blood loss and the other one is chronic blood loss. Acute blood loss, if the patient is conscious, even the patient will know the reason of it. The doctor, it's self-evident, you're losing blood. That itself is causing anemia. There is nothing much to explain as for the pathogenesis of this particular condition. Chronic blood loss may be slightly more complicated. This is because many a time the patient may not know that he or she is losing blood. An example of this would be a chronic ulcer, for example, a malignancy in the gastrointestinal tract or in the genitourinary tract, which leads to a loss of blood in small amounts over a long period of time. There is chronic blood loss. However, the amount of blood lost in each episode is so minuscule that the patient may not be aware of it. This sometimes can be detected using tests like testing for stool occult blood, etc. So in such individuals, due to chronic blood loss, they will slowly become anemic. The importance of such anemia occurring due to chronic blood loss is highlighted by the dictum that you should think of a genitourinary or a gastrointestinal malignancy whenever an elderly person presents with anemia. Another example of chronic blood loss, which is quite frequent, is that associated with fibroids in reproductive age group women where they present with menorrhagia. Here the patient will know that they are losing blood, and this loss of blood is chronic. It occurs during every menstrual cycle. This also can lead to chronic blood loss and anemia. Now, when we classify anemia, we like to pigeonhole each type neatly into different classes or different types, etc. But one thing to remember is the body does not recognize that we are classifying anemia. Many types of anemia can overlap in the same patient. So a person who has chronic blood loss over time will lose a lot of iron, and he will then land up with both chronic blood loss and iron deficiency anemia. So this is just whatever classification that we are discussing today, it is just theoretical to help us understand it better. When treating a patient, remember that nothing is black and white. There is always a gray area. Okay. Now regarding anemia due to increased red cell destruction, this is also called hemolysis. Hemolysis is, there are two types of hemolysis. It is the destruction of red cells, but depending on where the red cells are being destroyed, it can either be within the circulation itself, which is called intravascular hemolysis, or it can be outside the circulation, the major site being the spleen. Now, the spleen is an organ which acts like an obstacle course for red blood cells. It is a quality control manager for your red blood cells. The red blood cells, as you may know, have an average lifespan of 120 days. All through this 120 days, it goes through the splenic circulation multiple times. It goes through this circulation multiple times, and the spleen, the circulation within the spleen is a very complicated network. So the RBC has to be physically and functionally very capable to be able to maneuver through the complicated vascular network of the spleen. If the RBC is not flexible enough, it may be trapped in the spleen. Now, we will just take into account the shape of the RBC we discussed earlier. It is dumbbell shaped. That means the middle of the RBC is thin. This thin waist helps it to be very flexible. Now, because it's flexible, it can bend and maneuver itself through the various intricate spaces of the spleen. If the RBC is not flexible enough, or if the RBC is a little sticky, it can lead to entrapment in the spleen and then destruction by the splenic macrophages. This kind of hemolysis is called extravascular hemolysis. Because of extravascular hemolysis, there can be a proliferation of splenic macrophages, ultimately leading to an increase in the size of the spleen. So the features of extravascular hemolysis would be anemia, obviously, because there is hemolysis, jaundice because the red blood cells are being destroyed, and splenomegaly. Splenomegaly is what separates extravascular hemolysis clinically from intravascular hemolysis, the other kind of hemolysis. In intravascular hemolysis, the hemolysis is occurring within the circulation itself. So the red blood cells, they are destroyed within the circulation, so there is anemia. The hemoglobin within the RBCs it's leaking out, so there is hemoglobinemia. This hemoglobin can go out through the urine, so there is hemoglobinuria. This same hemoglobin, it can be converted to hemosiderin, it leads to hemosideриnuria, and of course, because the red blood cells are being destroyed, in this case also there will be jaundice. So to recap, in extravascular hemolysis you have anemia, jaundice and splenomegaly, whereas in intravascular hemolysis you have anemia, hemoglobinemia, hemoglobinuria, hemosideриnuria and jaundice.